So now we're going to move on to Dr. Kaveto Sikuvi, who is going to walk us through some of the different responses and experiences of his work in Namibia. So Kaveto, Dr. Sikuvi, can you hear us?
Right. Thank you, Rory, and thank you, FM, for inviting me to present Namibia, talk about Namibia's response and preparedness related to COVID-19. So the way of outline, I'm just going to talk about the pandemic timeline, especially related to Namibia, and then update you on our cases, and then Namibian experience on screening and triage, and then what we have done as a country. So next slide. So Namibia, for those who don't know, it's a SADC region, just next to South Africa and Southwest Africa. So we basically, it's a large country, about 800,000 square kilometer, with about 2.5 million people. So you can see that the population is very small, and we are sparsely populated. Basically, in our capital city, we have a population of about 300,000. That is Windhoek, and that is where I am currently. Pandemic timelines of SARS-CoV-2. So we all know where it came from, and it was identified in November last year in Wuhan, in China province. And WHO declared global emergency on the 30th of January. And they also declared as a global pandemic on the 11th of March. So, and we got our first case on the 13th of March, just 2 days after the global pandemic was declared. So, and then about 5 days after that, 4 days after that, our Honorable President of Namibia announced state of emergency. So just to help us to cap the spread of the SARS-CoV-2. So, and then after that, we went ahead to about 11 cases. And then on the 4th of April, the 16th case was announced. So, and that was our last case to date. So, and then lockdown was lifted on the 5th of May this year. So, and we will come back to the timelines a little bit later, just to explain a little bit why those timelines important, especially in our setting. So, as I said, we had about 16 cases, and all of them were mild cases. Only one with moderate symptoms. We didn't have any severe cases. We don't have any death. And out of those 16, 11 have recovered so far. So we have 5 active cases at the moment. And the status update is that they are all well, no symptoms at the moment. They are just testing positive. So this is where the cases are at the moment. There are 14 regions in Namibia. Yeah. So those cases are basically on those on the map that I'm showing you, mainly Erango region, and then Khomas region, which is Windhoek, and then you get one case which is in Karas region, way south of Namibia. So out of that, we know that the cases were imported, and 11 of the cases were Namibians, and then the other 5 foreign nationals. And our index cases were the Romanian couple, actually with permanent residence from Spain. So those were our index cases, and up to date, they still test positive for SARS-CoV-2. We are not so sure what does that mean, but they are still isolated at the moment. That is just for us to be more cautious as data comes in, so that we can be well informed what to do next. So, and out of those 16 cases, only 3 were local transmission. So, which means that those who the 3 were contacts of the cases that came from abroad. So those were the local transmissions, only 3. So we can go to the next slide. So so mainly my talk is mainly on what we did as a country and why we did it. So if you go back to the timelines, if you can remember that when we had our first case, the 2 cases, that we looked at what is the possibility and how are we going to make sure that we can survive this pandemic. So we looked at what is happening in high-income countries, and we saw how their health systems, which is uncomparable to our country's health system, how the virus has caused havoc and how they were not really coping. So that actually helped us to determine what are we going to do. Are we going to ride it along like what the others are doing, or we should try to put measures in place that is somehow detrimental to our economy, but however, we'll be able to contain or prevent further spread. So that's why our president, upon the health ministry's advice, decided to declare state of emergency on the 17th of March. That was just 6 days after the pandemic was declared. And that was just 4 days after we had our first cases. So, and then after we had about 10 cases, we had our Namibian lockdown. So the lockdown, what entailed was that we knew the cases were in Comas region and also Erongo region. So the borders were closed, and the Comas region and Erongo region were also closed from the rest of the country. So meaning that no one moves from Comas into the regions or to the other regions or comes into Comas, except if you have a permission. For example, if you are transporting essential commodities to the regions, and you will be screened and followed up wherever you are going to the regions, just to make sure that you don't develop symptoms of COVID-19. So those were the drastic measures that were done to make sure that the virus doesn't spread. So we can go again. Yes. So what we did was that we quickly developed or established a toll-free 24-hour call center that is based in Comas region in Windhoek, that is the capital city of Namibia. So this toll-free center consists of 16 telephone lines that the whole country can call in terms of if they have any symptoms related to COVID-19 based on the case definition criteria. And also, if they have any information regarding somebody they think who have traveled abroad, who came in, nobody knows about them, so that the surveillance can contact tracing do contact tracing on those individuals. And then also the toll-free center was established just to give information to the nation. If you have any questions, what is happening, it is a new disease and everybody was scared. Everybody didn't know what to do. So that was also the purpose for the toll-free call center, which is currently still operational. So, and then what we did was that the surveillance team was very active. The surveillance team and other teams, which is based on the WHO thematic pillars, which is about 8 of them, was established nationally, and then to coordinate the response of the COVID-19 pandemic in Namibia. So, and the surveillance team in particular had to do a lot of work in terms of contact tracing for the few cases that we had at that time, and also overall. So they acted really very fast, and all the contacts, high-risk contacts, were put in mandatory quarantine. And also what the government decided is that everybody coming from abroad, that is the nationals or permanent resident, since the borders were closed for foreign nationals. So everybody who comes in will be put in mandatory quarantine. So at the cost of the government. So they identified facilities across the country, in Comas region, in all the regions, and we know that at the stage where at this stage where most of the lodges hotels were basically becoming empty because we didn't really have a lot of tourists again coming in because we have closed our borders, and most of the foreign nationals have left to the countries since we were negative. So and we basically have a lot of those lodges who currently are running at a loss. So the government had to negotiate for some form of discount so that we can lodge in all the retainees from other countries. Especially, we had a lot of Namibians returning from South Africa. And so that is part of the quarantine that was done that has basically, we think that has really helped us a lot. So, and the laboratory thematic pillar came on board, and with safe specimen collection and transportation to the laboratory. So currently we are only testing the cases in Windhoek. So that's why the transportation was done as safe as possible. In terms of lockdown being lifted, so the lockdowns consist actually of 3 weeks each. So the first stage was 3 weeks. 3 weeks, based on the incubation period for the coronavirus. So, and we know that from the literature, 14 days, and then we added 1 week just to make sure that we don't see any other activities related to COVID-19 disease. So, and then after the first stage, the lockdown was extended again for another 3 weeks. This is because the last case, number 16, the contact tracing was actually complicated with a lot of contacts, that was traced. So we decided together with the policymakers that we needed a little bit of time to see what is going to happen within the next 3 weeks again. So then the lockdown was extended for another 3 weeks. So totally the full lockdown was for 6 weeks. So we know about the economic issues, but then we thought, if we reach crisis, we will again have economic hit, as well as, crisis where we won't be able to really contain or treat all the cases in the hospitals. So that was the lockdown strategy. So, after the lockdown was lifted, we had to come up with measures again, which is now stage 2 lockdown, where the Comas region and Erongo region, where the cases were, because we didn't have any evidence of community spread, we decided to lift that, and then people within the country are free to move to different regions. While all the cases, maybe I didn't mention that, all the cases were put in mandatory isolation in government facilities, just to make sure that we don't have any other spread from these cases. So then we expanded our testing, and all cases that came to the hospital presenting with respiratory symptoms were tested. And because we had a lot of journalists covering the news and also trying to get stories from hospitals, so we felt we can also test them just to, they were not on a scientific base, but because of they are journalists and political maybe pressure. So, and then all high-risk shop staff, they are also part of the testing, expanded from the initial case definition. And then healthcare workers, especially those ones who were at the forefront, emergency units, in triaging areas. And then mainly also we needed to focus on our borders, because we didn't see, after the extended lockdown, we didn't see any evidence of community spread from the hospitals. The mortality rate were not increasing, and we didn't see any abnormal respiratory symptoms or any other symptoms from the usual based on the seasons we are in. And we also looked at Home Affairs records, whether there was any recorded deaths that, surge in the death. We didn't see that. So that gave us a confidence that we didn't really have community spread. However, we were still on high alert and making sure that especially the truck drivers were followed up and tested. Since most of our truck drivers are coming from South Africa, Zambia, and the South African ones especially is that we depend almost 90% to South Africa, and in terms of our daily consumption, we depend on South Africa. So we couldn't stop the truck drivers from coming in, otherwise we will go hungry. So but we have put measures in place to make sure that they don't mix with the locals. If those ones coming in, they get tested and they get followed up, just to so that they don't mix with the locals. So screening and triage. So screening points at every point of public places, the shops, the malls, ports of entry, and all health facilities. And also observing social distancing, temperature, hand hygiene. And in hospital facilities, we have limit visiting times. We reduced from the normal 1 hour to 15 minutes, put into batches. Also, and everybody who comes into the hospital is screened, and then checklist just to make sure that they don't exhibit any signs and symptoms of COVID-19, and also traced in a way that not many people visit one person at a time. So we decided to establish COVID-19 centers from the beginning. So what we did was we because of our resources, limited resources, we decided that if we treat patients within the hospital, based on what we have seen in high income countries, we will make mistakes and spread the disease from the hospital. So we decided to have established, dedicated COVID-19 screening health centers in all regions. So we started with City Windhoek. What we did was we turned one health center completely. We stopped the normal activities at that health center, and we made it as a COVID-19 screening center. And this also consists of 8 beds, where if we have suspect case who is sick, who needs admission, but not high care admission, can be admitted there while waiting for the results. So, and the whole center is just dedicated for COVID-19. So the other activities, ARV and other activities, was diverted to other health centers. And we also established COVID-19 treating facilities in terms of ICU. We have 26 beds just for ICU, COVID-19 ICUs. That is up from the normal ICUs in the hospital. Currently, we are looking at, if we get a case, we are going to put them in the established ICU centers rather than using the normal ICUs for the same purpose, transmission within the hospital. And then we also established isolation units throughout the country. So far, 254 beds, and more units are being. We are trying to get more units being capacitated. So human resources, based on the WHO guidelines, national, we are using the thematic pillars, and we have also kind of replicated that into hospital-based committees that have to deal with case management, for example, surveillance and IPC. So this has basically helped to train the staff and also to prepare in terms of resources mobilization within the hospital level, and also identifying screening facilities. So, and then rapid response team, both on integrated rapid response team, which consists of the doctors, the surveillance team, and the IPC team, and environmental health. So this rapid response team, what happens is, if the call center gets a call that there's somebody who is suspicious, let's say in a township where we if the person is exhibiting some form of or meets the case definition criteria, and the person definitely needs to come in for testing. So if they have a car, we will call them to come in to the dedicated COVID-19 screening center. If they don't have a car, then the rapid response will go to the community, accompanied by the police, just to do the test there, because we don't want them to take taxis to come, because of the exposure to other people. So that is what we have done. And the medical rapid response teams, They are the ones working at the health center. And also, if there's anything in the hospitals in terms of especially when we started, when the training was not widely to everybody, they would go out and do the testing also in the hospitals. And one thing about the medical rapid response team, so they were removed from their daily work, and everybody from different departments who was incorporated, and they were, in teams of about 8. So the idea is we took them out of their departments and we took them out of houses. So they were housed outside at a lodge where they are just working on also the patients who are in isolation, the positive ones. So this medical team don't go home to their own home. They go to these facilities provided by the government. And after 2 weeks, they will rotate with somebody, and then they will go for quarantine for another 2 weeks before they come back into the main system. So just to make sure that they are not exposed and exposing the system. So, and now we have been doing ongoing training for healthcare workers and the public through radio, TV, and then especially healthcare workers integrated training via visual means and practical in PPE, donning, doffing, taking swab, and so far we have trained about 3,000 health workers throughout the country, so that it is a way of preparation. The idea is that each department, wherever they are in terms of ophthalmology or emergency medicine, that if we reach crisis, everybody knows what to do. Instead of calling somebody from emergency, you need to come and help them. So that was the idea for integrated training, which is still continuing. So then next slide. So in conclusion, we remain very vigilant. Our borders still remain closed. It won't be closed forever. We depend mainly from outside, especially economic activities from outside countries. So, but at the moment we are focusing mainly on the borders, truck drivers, and testing them all. We are continuously preparing for possible surge. We are recruiting more volunteers, and then capacitating all those facilities that we have identified. So, and the challenges we are having currently is the border control. Truck drivers, South Africa, Zambia, Botswana. So it is difficult to control them. Some of them, they just drop off the load and go back. And then some of them, they say they are dropping off, and then they end up somewhere else. It is very difficult, and that is where most of our resources now is going, so that we can make sure that we don't have that spread. And also, we know the whole world is crying of PPEs, and that is the same applies to us. We are struggling with that, but the government is trying what they can to procure more of the PPE, and local people are trying also to come up with producing PPEs. And testing kits, also the same. I'm told there's a queue out there for people who do the testing kits. Hopefully, with the rapid test or gene expert coming up now, maybe it will ease the burden. So far, we have tested about 1,700, going to 800 people, and one may say that it's less people we have tested. However, it was because we started early in terms of lockdown and preventing of the ones that we know from spreading. we were testing, based on scientific knowledge and on our case definition, and also on observations of what is happening in the hospitals. Thank you very much. That was Namibia experience in short.
Great. Thank you so much, Dr. Sikuvi. It doesn't look like we have any questions at the moment. I think it's very much because your presentation was so comprehensive, but if any questions do come up, we're going to be sharing the PowerPoints of both Dr. Parker's presentation and Dr. Sikuvi's presentation. So that ends our webinar for this week. Thank you all for attending. Thank you so much to our speakers, Dr. Parker and Dr. Sikuvi. We learned so much during this session and are so grateful for the time that you guys have taken and for the fight that you guys are putting on in both South Africa and Namibia. And thank you for sharing your knowledge and experience with us. Just as a quick aside, we have a survey that we're hoping you all can take before you leave this webinar. It will only take 5 minutes and it helps us to improve upon what we do. So I've just messaged it in the chat. If you click on this link that I've just sent in the chat, it'll take 5 minutes to complete. It helps us to create content for you all and also improve upon the way that we do these webinars. We're really excited to see you all next week and look forward to sending you more information on who our speakers will be and what the topic will be. Great. Thank you so much, everyone, and have a great day.